Hello, and welcome to this ASCO Journal of Oncology Practice podcast. This is Dr. Bob Miller. I'm a medical oncologist from the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins and a member of the JOP editorial board. And tonight, we're going to be discussing an article in the September 2010 issue of JOP entitled National Practice Benchmark, 2010 Report on 2009 Data. And I'm pleased to have as our guests the two authors of the article, Tom Barr and Elaine Towle. Tom is the General Manager of Oncology Metrics, a division of Altos Solutions. Oncology Metrics developed and conducted this benchmarking survey. In fact, this publication is their fifth annual survey. Tom is well known to ASCO as a past member of the Clinical Practice Committee and a frequent speaker at the ASCO annual meeting. So welcome, Tom.
Oh, thank you. It's my pleasure to be here.
And also with us is Elaine Towle. Elaine is also from Oncology Metrics, and she is currently the Director of Consulting Services. Elaine has extensive experience in oncology practice management as an administrator and a consultant. And like Tom, she is well known to ASCO members and staff. And welcome to you as well, Elaine.
Thanks very much, Dr. Miller. It's a pleasure.
So I wanted to talk a little bit about this survey and put it in some historical context. I understand that your company has done this survey annually since 2004, but maybe you can tell listeners a little bit about who is exactly being surveyed and a little bit about the survey instrument. Has it changed over the years, and what are you really looking for in this survey?
Sure. I'll start. This is a survey that we email to a pretty diverse database that we've developed over the last 5 or 6 years. It's really targeted primarily to physician-owned private practices, but it's not exclusive to that population. So we do collect some information from hospital-based practices, a little bit of information from academic practices. Participants enter their data through an online portal, and then we collect the data through that online tool and develop it into an analytical data set that we work from. Mm-hmm. The core metrics haven't really changed much. We look at practice expense and cost of drugs. So those are really core things that we've looked at every year. But in addition to those things, we do make changes that reflect the current environment. A couple of years ago, we started focusing on things like electronic medical records and trying to get a sense for what systems were being used and how practices were using them. That's becoming a little more standard now, and this year we've spent some time asking about practice guidelines and clinical pathways, so we try and stay current with what's happening in the current environment, practice environment, and economic environment.
Mm-hmm. How about the benchmarks? Can you tell me what the particular benchmarks are and what they're designed to measure?
Sure, let me address that one. Elaine and I choose these benchmarks, and really they're based on our judgment of a number of variables. First of that is the ability of practices to report an accurate number. Mm-hmm. Of course, if we don't get an accurate number, that's just not helpful at all. And then we really want to get at the relevance to the practice management of the deliverable benchmark. We're trying to produce benchmarks that people can use to actually manage and run their practices. And then finally, we try and pick benchmarks where we think there's a strong likelihood that comparable data can be gathered from a wide variety of practices. Since this goes out nationally, we really do have quite a cross-section that comes into play here. So then taken all together, the benchmarks are designed to let an individual practice understand sort of where they fit into the universe, how they compare to the average of all of the other participants in the survey.
Mm-hmm. I see. How about the practices that you did survey in 2009? Do you think that they were representative of the landscape of U.S. practices? And tell me a little bit about the demographics.
Sure. We ask practices to identify their practice structure, and we ask them to indicate whether they're physician-owned private practice, hospital-owned. We provide a variety of options. And this year, our respondents reported that about 71% of them were from physician-owned private practice. That was down a little bit from last year, down fairly significantly from 2007, when over 85% of our respondents indicated that they were physician-owned practices. Now, whether that really is representative of the landscape, I'm not sure, but it seems to be consistent with what we hear and what we're seeing in practices, even if it's anecdotal information. We know that the practice environment is shifting, and our information seems to be consistent with that.
So do you think that's the practices are consolidating more and they're looking at other structures then?
I think both of those things are true. I think some of it is practices consolidating, so perhaps there are fewer entities out there, and some of it is practices joining other entities. We know of practices that either have become hospital-owned or have become part of academic medical centers, so we know that there's a little bit of all of that happening right now.
I was surprised with the report that 31% of practices thought that they were going to stay the same only for about a year, and I remember reading that and thinking, wow, that's an amazing number. And what's your take on that? Do you think that's representative of the current conditions?
Yeah, I think it is, and that was a new question. We'd never asked that before. What we asked practices this year was how long they expected their current practice structure or ownership model to remain unchanged or viable. And as you said, 31% said either they were changing right now or that they expected it to only remain stable for about a year. And I was struck by that as well. I thought 31% was pretty high. Only 53% of the respondents said that they expected their practice model to remain unchanged for the foreseeable future. I think that's as striking that only about half of the respondents think that they're going to be stable as far, into the future that they can see right now.
Well, let's talk a little bit about the benchmarks you looked at. So you analyzed total revenues, total expenses, and this metric called cost of goods paid for. So tell me a little bit about those things.
Sure. Those are some of the key metrics that we look at every year. We ask practices to report to us their total practice revenue, that's collected revenue, total practice expenses, and by that we mean all cash that was dispersed. So that includes salaries, compensation, their drug cost. And then we also specifically ask about the cost of drugs. As you know, that's a huge driver for practices, and that's this metric that we call cost of goods paid for, or COGPF. This year we took our analysis to a little bit different level in that when we ask practices for this data, we're really encouraged by the number of practices, especially this year, that are providing information, that are interested in the survey, and that can provide good information. Uh-huh. To us, that indicates that practices are really spending a lot more time focused on the business side of their practice. But sometimes we get practices that, for one reason or another, start the survey, can't finish it in a very complete fashion, or just aren't that interested and just plug numbers in. And in the past, we've had a little trouble identifying that until we get well into our analysis, and all of a sudden we get data that just doesn't make any sense. This year we tried something a little different and decided to run all of the data we received through an inclusion-exclusion process to make sure it made sense and was consistent before we analyzed it. And those three, total revenue, total expenses, and cost of drugs, were key to that. So, for example, we looked at the data that practices reported, and if their cost of drugs was greater than their total practice expense, we knew that was wrong, that either they made an error in reporting or the data just wasn't real and somebody was just plugging information in, and we excluded those practices from the analysis. I think that makes our data set a little stronger than it's been in the past. Mm-hmm.
Okay. So talk a little bit about the importance of new patients in a practice. You mentioned that's really a barometer of the health of a practice. Why is that important?
Well, I'm glad you really asked that question, because it really is the backbone for strategic planning, operations planning, patient flow, staffing. And without a healthy flow of new patients, your practice really can't survive very long. So we know now that the future holds lower unit cost reimbursement per patient. We can look at the demographics of the growing Medicare population, and we can look at the financial realities of the world we live in, and we can see that that's just a necessity. And while we know that there have been lots of practices that have really generated efficiencies, particularly clinical management tools like an EMR look to become effective, that there's really a way that practices can get a lot more efficient over the next 3, 5, 7 years. And we've seen this trend for a while. In the past 7 years, we've seen the number of new patients per medical oncologist rise from about 235 to now we're seeing close to 360 new patients being managed per oncologist per year. So as we look to the future and we know that we're going to have decreasing margins, and we look to the past and see we've been able to increase efficiencies, then the only way that this game looks like it can play out is for volume to continue to go up. That is, the number of new patients per doctor coming into the practice need to rise so that it can offset that shrinking margin on each of these patients coming in here. And really, we see it here, of course, in our business in medical oncology, but it's the same throughout healthcare. The healthcare industry will have to become much more efficient and much more value-driven than it has been in the past, and that's a trend we've seen in many other industries.
That's a striking increase in new patients over 7-year period of time. So I think that's very interesting that practices were able to ramp up that much in a relatively short period of time. How about the cost of drugs? Now, that's of course a huge concern for anyone who's buying and selling drugs. But I thought it was also interesting how your data showed that the overall increase between 2000 to 2007 through 2009 was really striking with actual costs, and this is in a time when everyone knows that the margins are going down.
Well, you're right. As we look at those trends in total revenue and total practice expense and cost of drugs for 2007 through 2009, it's really striking that the cost of drugs continue to increase year after year, but the margin on those drugs continues to go down. So what that really represents to us is a higher level of risk. That is, we have a higher embedded cost when we provide services to an oncology patient in terms of those drugs, and then we have a lower margin that's expected when we actually get paid for those drugs. So that means that if we don't get paid for them, we've really got a very steep downside to that whole equation. Still, we see that practices have adapted to that higher level of risk and have managed it pretty well. Even as the margin has gone down, we believe that we're seeing within the practices a better ability to manage that inventory. In fact, physician-run practices are remarkably adaptive. You mentioned that 7-year period to be able to ramp up from to 360 patients. And what we've seen in the past is that when these changes come about relatively slowly, that practices really are able to adapt, and this is a good thing. Of course, there is an end to what can be accomplished by increased efficiency and being able to put more patients through that system. But I think right now we're really not clear on, are we close to that end point? Do we still have a good way to go in terms of efficiencies? My own thoughts are that we do have a good way to go in terms of becoming more efficient in our ability to provide care.
Let's talk a little bit about inventory. I remember when I was in community practice, managing that inventory was just such a tense thing. You couldn't stock up your Pyxis cabinets, and you of course wanted to have drugs on hand to treat the patients. But it sounds like the trends are for less inventory on hand.
Well, that's right. We do see that. We encourage practices to keep less inventory on hand. But it's really more about just managing the impact on daily cash flows. As we look at inventory that's sitting on the shelf, if one assumes that it's paid for, and hopefully it is, then it really, from an accounting point of view, is the same as cash in the bank. So when we see that we have a sizable inventory reduction from one year to the next, what the effect of that is that it's just freed up cash. Now, as we all know, unfortunately, very few practices retain earnings. Our history has been cash accounting, and so when cash is freed up through an inventory reduction or similarly through a reduction in days sales outstanding, then that freed up cash typically just leaves the business. That is, it's bonused out to the physicians, paid out in terms of salary. So kind of counterintuitively, now we've actually put our business unit in a weaker financial position. That is, it has less cash resources on hand to be able to manage risk. One of the things that I've talked about for years is the necessity for for our business units to start really not distributing all cash, not starting every January 1 bankrupt, and to actually retain some of those earnings so that there's a buffer, a little cushion that's set aside for the inevitable rainy days that look like they're going to continue on for a while.
So you mentioned the days sales outstanding, the DSO metric, and you did report on that this year. Is that something that you have been tracking with this survey?
Well, we did report DSO this year, and it was at about 32 days, which is very consistent with anecdotal reports and with the work that we do with practices around the country, so we're pretty comfortable with that information. We haven't looked at it in this particular survey recently, but we have another benchmarking group that we work with, a benchmarking collaborative called the Oncology Circle, and we have been studying it there fairly consistently over the last 7 years, and we've been watching it go down a bit. So I think that's really a positive thing. And I think the primary driver of that is in this changing economic Medicare payer environment, many practices are putting increased focus on patient financial counseling as a way to identify bad debt early and perhaps not accumulate bad debt that might have been accumulated in the practice in the past. So if you can eliminate that bad debt up front by perhaps finding other places for patients to be treated, if you can't provide drugs for the patients, et cetera, then you're going to eliminate bad debt and, just by the nature of the beast, decrease day sales outstanding. I think that's a good thing. It was also interesting to see that about 50 practices in the survey this year did report having patient financial counselors at a rate of about 0.3 per one full-time equivalent hematology oncology physician. So practices who are working with these patient financial counselors or patient financial advocates really are embracing that system.
Yeah, I think that is a new trend because again, I remember when I was in practice, we used to have one of the scheduling people do that. It was sort of a job that was passed around the office, and then I think that we recognized pretty quickly what an important job that is to do it well. So I think your DSO data speaks to that somewhat. So I wanted to maybe you could just give me your 20,000 foot level view on this. What do you think the health of oncology practices is in the U.S. right now? Are practices, are these desperate times like you sort of hear anecdotally, or is it really the opposite? Are practices becoming more savvy and efficient? I mean, what do you think your data show?
I really think that both of those statements, that is desperate times and increases in market awareness and efficiency, both of those statements are supported. And what I think our data shows and what we see as we work around the country is it really depends on where you are and what your circumstance is as to whether these times are desperate or whether they look like opportunities for you. As margins dropped, inefficiencies become revealed. That's just the way business works. And the basic financial weakness of the cash business structure can really become pretty apparent. That is, if we know of a practice where folks borrowed money to pay physician bonuses at the end of the year and were bankrupt by mid-year. Yeah. So poor cash management will absolutely lead to desperate times. And at the same time, a lot of practices have really responded to environmental changes and have found ways to become more market savvy and more efficient. So increased productivity, we believe, largely hinges on seeing more patients, as we talked. To see more patients, you have to have more new patients coming into your practice. And you really need to see those new patients with the same staff, not more staff, than you saw before. So strategies that are used now but weren't used in the past include the patient financial advocacy, as Elaine mentioned, as a way to reduce what will ultimately become bad debt. We know we've seen dramatic streamlining in billing and collection processes, as noted by an increase year over year in the total dollars collected per FTE in that billing and collecting department. Mm-hmm. A lot of this is business process management, and there are better tools out there to do that than there used to be. And last, we really believe that the use of non-physician providers or physician extenders has been very helpful in getting from that 230 number to the 360 number of new patients per doc per year. And we do see not just a few, but but a handful of practices that are getting up into the 400 and 450 new patients per year per doc. And they're able to do that with the use of mid-level providers. And then as we saw, even though margins are going down, we believe practices have gotten very good relative to where they were 10 years ago or even 5 years ago at managing inventory. Mm-hmm. That is making sure that everything that gets on the shelf ends up off the shelf and gets billed for. No shrinkage, no waste. So we think that those challenges are really related to markets and that both extremes exist. Mm-hmm. We know there are practices that are in expansion mode, and we've certainly seen a number that have ended up as employed by the hospital or in some other relationship where they don't have to bear business risk any longer.
Mm-hmm. It's good to hear you don't think the news is all bad, because it's easy to kind of get into a tailspin about some of these things. So that's encouraging to hear that, Tom. So your survey, you've been doing this 5 years now, I guess. I'm guessing you're going to plan on continuing to do this. So what's your company's next step with this survey?
Yeah, we do plan to continue to do this. We actually generally start planning for next year's survey around the day we launch this year's survey. That's when we think of the questions maybe we should have asked or the questions we definitely want to ask next year. One of the big challenges as we think about the survey next year is the whole issue of new patients. That's a core metric, as you've heard us say. It's a really important thing for us to measure. And this year we don't have consultation codes, which is one of the way practices have reported it. So we're looking to think about how we're going to help practices define new patients and encourage practices to think about counting people rather than codes. So we're working on putting the language together for that right now. We're also really interested in the high tech and EMR incentives. So we'll be asking practices, how they're faring, getting ready for that to see if we can get some sense of what the market's doing and whether oncology practices are going to be able to take advantage of that $44,000 incentive money. And we'll continue to monitor revenue and new patients using the terminology we've developed over the last 5 years. We have a 10 or 12 page glossary of terms now. Uh-huh. So we'll use our standard terminology so that we can continue to look at trends, because increasingly I think people are really interested in trends in these really key areas of practice management.
Well, that's great. Those are some great perspectives, and certainly wish you well with the survey next year. We'll all be very interested to see those results. So I want to thank our guests, Tom Barr and Elaine Towle, very much for sharing your work with us on this very important topic. It's really been great having you, and hope you can join us again someday.
Thank you very much.
Look
forward to that.
And to our listeners, I encourage you to take a look at the entire issue of the September Journal of Oncology Practice for lots of interesting and practical content. If you're an ASCO member, you may have already received your paper copy in the mail, and if not, it's coming shortly. Most of the content of each of our issues is available online at jop.ascopubs.org. And if you're not an ASCO member, please consider going to asco.org and joining for access to the JCO, to JOP, and really a host of other important benefits. So this is Dr. Bob Miller for the American Society of Clinical Oncology. Thank you very much for your attention.